I want to welcome everybody to, I guess, our first inaugural endoscopy cafe expert conversations. And we, where we come from with this is when we were fortunate to go to Thailand, I guess it's still this year, to observe Nantali's amazing work. We really were struck by the fact that it would be wonderful to have an opportunity for us to get together and just discuss cases in a very relaxed atmosphere. And that was what the goal of this event is about. And we thought we absolutely have to invite our good friends to chat with us and tell us what are we supposed to be doing in the difficult situation. So that's where it came together. And we have to thank Mary Lee Krinsky, who is absolutely amazing and comes up with this amazing names. And that is absolutely reflects what we wanted this event to be about. As we imagine or not imagine having a cup of coffee or tea and just discuss the cases and have expert conversations. So without further ado, I hope you guys start by introducing yourself, make my job easier, and we'll start with our first case presentation for about 10 minutes, and then I leave 20 minutes for discussion, and then go to Vignap case and do the same thing, and then we'll be done. All right, I'm going to start with my partners in crime, Dr. Krinsky.
Oh, hello, good evening, good morning. I'm Dr. Mary Lee Krinsky. I'm an advanced endoscopist at UC San Diego in San Diego, California. And I'm one of the co-founders of the Association of Women Endoscopists, who's bringing this wonderful cafe to you all. Anyhow, enough about me. Phoenix, Dr. Nguyen.
I'm Phoenix Nguyen. I'm an interventional endoscopist. I work in Newport Beach, California, and I'm one of the co-founders for ABQ.
And we're going to go to Nantali. Dr. Paswazli, please.
Yeah, hi. Yeah, all good. Good morning from here, Bangkok, and good evening to you guys. My name is Nantali, and I'm currently the president of the Women in GI Network Asia Pacific, and that is WIGNAP. Also the president of the Thai Association for GI Endoscopy, and I'm so happy to be here. Thanks to all of you for putting together this program, and I hope to continue this program for many years.
And our absolutely outstanding experts today, Dr. Amy Tyberg.
Hi, everyone. Amy Tyberg. I am an advanced endoscopist in New Jersey. I was working at Rutgers Robert Wood Johnson, but I'm actually transitioning over to the Hackensack Meridian system as we speak. So I'm kind of in a limbo transition period at the moment, but I'm so thrilled to be here. Thank you so much for having me. And I apologize for my voice. I'm just recovering from COVID a couple of days ago, which is hard to believe we're there again. But luckily my voice is back enough that hopefully I can still contribute well to
Of course. And
Thank
Dr.
you so much for
Kaur.
having me. Yeah.
Oh, thank you for having us.
Hi, I'm Christopher Kaur from Singapore General Hospital. I work very closely with Nantali because I chair the GI TAP educational group, and that stands for GI Task Force Asia Pacific. So we have our two component organizations are an EUS educational group called EUS TAP and WIGNAP, of course, which is huge component of GI TAP. So we really do a lot of work together, and so this is just a terrific opportunity. Thank you for having me on board. I'm an interventional endoscopist as well, and I'm ready with my espresso this morning.
So you're on board for sure. And let me introduce Dr. Lau, who is going to start with the first case. And Dr. Alao is interventional fellow this year at Harbor UCLA. Please have a start.
Hi, my name is Hawa Alao. I'm one of the new interventional advanced gastroenterology advanced fellows at Harbor UCLA, and it's nice to meet you all, and I look forward to the presentation. So we have a 31-year-old Brazilian male presenting with a 2-week history of right upper quadrant abdominal pain, chills, non-bloody, non-bilious emesis 5 times on the day of presentation, non-bloody diarrhea, and abnormal hepatic panel. His past medical history was ulcerative colitis, primary sclerosing cholangitis, and he had no surgical history. His medications for his ulcerative colitis were prednisone 10 milligrams daily, Xeljanz 22 milligrams daily, and he was allergic to amoxicillin. He had just moved to California a year ago, unemployed, and didn't have any significant other social history and no significant family history. Pertinent physical exam was that he was fatigued, ill-appearing male, sclerolicterus, tenderness in the right upper quadrant with mild guarding, hepatomegaly on palpation extending to the right lower quadrant. The spleen tip could also be palpated and felt at the left lower quadrant, and he was jaundiced. Here was the initial laboratory assessment showing you a leukocytosis of 19.7, normal basic metabolic panel with cholestatic hepatitis, and I'll go through this, AST of 69, ALT of 91, alkaline phosphatase of 515, a total bilirubin of 2.2, and an albumin of 3. And here you can see that his coagulation panel was normal. And here is just, again, the total bilirubin of 2.2, direct bilirubin of 1.3, and an albumin of 3. So initial CT abdomen and pelvis with contrast that was received showed that he had a large distended gallbladder with gallbladder wall thickening, pericholecystic fluid, and possible ischemia concerning for gangrenous cholecystitis. Also of note was mild, moderate to severe, read as moderate to severe intrahepatic dilatation of the ducts with hepatomegaly and described as fibrofatty nodular cirrhosis of the liver, as well as a big spleen. It was also mentioned that he had pyroesophageal varices. So his hospital course, he was diagnosed with acute gangrenous cholecystitis, status post laparoscopic cholecystectomy with IOC that was positive for distal defect filling in the CBD. Micronodular liver was mentioned concerning for cirrhosis intraoperatively, but no biopsy was taken. Also, intraoperative ERCP with sphincterotomy was performed that showed pus and extraction of 3 pigmented stones, and a 10 French 7-centimeter plastic stent was placed. So here it shows you, this is a liver-associated enzyme that's showing the course of his liver panel over the hospital day course. So here you see the AST and ALT, which represent more of the hepatocellular pattern, and the cholestatic enzymes. And over the course of the hospital course, unfortunately had increased elevation of ALT, AST, as well as cholestatic enzymes. More importantly, I think, is this figure right here, where you can see when the patient was admitted on the 7th of August with leukocytosis, significant cholestatic hepatitis that continued to increase over time, as well as hypoalbuminemia. And here the arrows are showing the different times that interventional endoscopy were performed. And we will be going over these in a minute. So here, the first was a upper endoscopy that was done on hospital day 8. The reason why this was done was the fact that post-hospital course, post-surgery, the patient's alkaline phosphatase continued to climb down, but unfortunately started to double and climb up at hospital day number 8. And so we decided to go back in. And EGD showed superficial prominent distal esophageal varices. And here is an ERCP cholangiogram that shows significant dilation of the ducts. Not only that, but the right posterior bowel duct here, intrahepatic bile duct, you can see has some fill-in defects, most likely from sludge. And this was not an area that the ERCP tools that we had can go all the way too. So we did a lot of copious normal saline wash of the area. 3 large pigmented stones were removed with balloon extraction. And this time it was determined to put a metal stent, a 8mm by 80mm metal stent was placed. Repeat CT abdomen and pelvis that was done on hospital day 16 showed prominent and significant dilation of the intrahepatic ducts. The patient continued to have abdominal pain, and the cholestatic hepatitis did not subside. Here we did a EUS on hospital day 16, and what you're seeing here is a portal vein, the portal confluence as it becomes the splenic vein here, but more importantly, significant collaterals in this area. And here is the body of the pancreas. So again, hospital, and we're here now at hospital day 16 with another increase in cholestatic hepatitis. His white count is now going up despite the patient being on antibiotics throughout the hospital course stay. Here, I'll be playing a video just showing how dynamic the flow of the portal vein was during the EUS, concerning for possible portal hypertension. And I'll be showing a portion of the EUS that was concerning. We looked at the left portal vein, and it was concerning for decreased to no flow. However, a CT venogram that was done later on by radiology was read as normal. Here, also showing the left portal vein with a normal undulation of flow waveforms. And here you're looking at the left left hepatic vein with normal flow as well. And here is the IVC with the middle hepatic vein here, again with normal flow. So a cholangioscopy was done this time. This is the 3rd ERCP that this patient had. And we could see that they were aiming at the right posterior hepatic duct, and you can see that there was a stone stock pretty deep in the duct. This was pulverized with EHL, and a basket was used to retrieve the stones. And here is the air cholangiogram post ERCP with the metal stent in place. Again, the patient, unfortunately, his labs continue to go up in terms of his alkaline phosphatase. So an EUS performed again showed multiple collaterals concerning for portal hypertension. Cholangioscopy again just showed that he just had a large burden of intrahepatic stones, which we continue to work on and remove and pulverize. And here is hospital day 22. You can see that the hilum as well as the CBD, there's decreased dilation, probably looked more like his normal size here. And decision was made at this time because the patient also wanted to go back to Brazil for quote unquote rest. So we decided to put in a 10-12 plastic stent at this stage. So in summary, we have a 31-year-old male with history of ulcerative colitis and primary sclerosing cholangitis presenting with acute gangrenous cholecystitis, cholestatic hepatitis with dilated intra and extrahepatic bile ducts, EUS findings consistent with portal hypertension, multiple collaterals without overt findings of cirrhosis, normal platelet count in the patient, and ERCP cholangioscopy showing multiple stones in the intrahepatic ducts. So our questions for the experts are the findings consistent with his native diagnosis of primary sclerosing cholangitis? How would you manage this patient moving forward? Given the portal hypertension findings, would you evaluate this further? And if yes, how would that go? And also, if you're not able to get your needle into the portal, into the middle or hepatic veins, what other measures would you do at that time? And we look forward to this. Thank you for allowing me to present.
All right. Who wants to tell us what we need to be doing at this point? The only thing I would add, at the last ERCP, we were able to, with cholangioscopy, to get into the that right posterior quite deep, And we felt that at least, and we went sort of conscientiously through everything, and we did not see remaining stones, at least everywhere we could examine. And eventually his numbers sort of improved. Mary Lee, please.
Well, I was just curious on I didn't notice any dominant strictures. Did you?
No, there was definitely no dominant stricture of any kind. Emmy, what should we do?
I think it's a really interesting case. You know, PSC this is sort of an atypical presentation of PSC. You know, certainly as advanced endoscopists, I think all of us, when we have PSC patients, you know, we always approach them with a little bit of dread because, you know, we help them when we stent across dominant strictures, but at the same time, their risk of cholangitis and prolonged complications after any intervention are high. And I always, you know, worry about these patients because their cancer risk is so high, whether it's cholangio or gallbladder cancer. You know, it's they're always a very difficult patient population to treat. But I will say, in my experience, I don't usually see a heavy burden of stone disease in my PSC patients. You know, it's especially intrahepatic, you know, unless there's a really tight stricture and there's stones that form upstream because of stasis, you know, but it's sort of a rare presentation of PSC. So it's a really interesting case. I mean, I think everything was done right. You have to balance, you know, the risk of going in and doing an intervention against the benefit in these types of patients. And, you know, I think when there's persistent stone disease and bilirubin that's just not responding, you know, you need to go in and look and make sure you clear all the stones. But it's definitely an unusual presentation for PSC.
We actually questioned diagnosis of PSC. Anantali, do you think it's PSC?
You know, when I first saw the cholangiogram, although it wasn't like a complete cholangiogram, I thought that this could be if this patient was coming from Thailand, we would have thought this is oriental cholangitis with lots of intrahepatic duct stones.
Yeah,
but I think that a Brazilian may have, you know, you can call it sclerosing cholangitis or sclerosing cholangiopathy associated to intrahepatic duct stones. I think Brazilians have, you know, some prevalence of IHD stones as well. Right. So, you know, I think that because this patient presented himself in the US and he has underlying disease of ulcerative colitis, and therefore diagnosis of PSC was brought up. But if you look at the cholangiogram, you can see that yes, you do have some irregularity of the ducts, intrahepatic ducts and extrahepatic ducts. You also have some multifocal strictures or dilation, but it wasn't like the classic beading appearance. If you could pull up the cholangiogram one more time. And also when you did the cholangioscopy, you know, I think that would be another opportunity to take a look and see whether the patient has multifocal stricture, fibrotic stricture, right? And he didn't. Exactly. So I think I also question the diagnosis of PSC as well. I would think that this patient has intrahepatic duct stones. I think this could be associated with stone disease, and what we're seeing is the consequence of long-standing retained intrahepatic duct stones and extrahepatic duct stones as well. I do agree that this patient has multiple collaterals, and the initial CT scan, you can kind of, an intraoperative finding, you see cirrhotic or nodularity of the liver surface. And I think if you see that intraoperatively, I think that, you know, pretty much definite diagnosis of cirrhosis, even though the endoscopic ultrasound didn't really show any strong evidence of cirrhosis. So I would think that this patient started off with intrahepatic duct stones or stone-associated disease complicated by maybe secondary biliary cirrhosis leading to portal hypertension as demonstrated by multiple collaterals and esophageal varices. If I saw your beautiful EUS image that you can see the main, the left hepatic vein as well as portal vein. I think if you can, identify the window to get the needle in there and do a portal pressure gradient measurement, I think that would help, assessing the portal pressure. But even if you can't do that with the evidence of esophageal varices, that tells you that at least the portal pressure gradient should be at least 12. So, as far as what to do, and I think that this patient, the reason he continued to have cholestatic jaundice is because there were some retained
Right.
stones inside, and also with recent infection and, both cholecystitis and cholangitis, he may have had some degree of decompensated chronic liver disease. You can kind of see a prolonged hyperbilirubinemia. The alpha that's persistently elevated is probably because of the stones, as well as, I don't know if any of these period he's got some evidence of sepsis. It
Yeah,
could
he
be a
was.
combination, right? It could be a combination of stone plus cholestatic jaundice related to cholestasis of sepsis, and leading to some degree of liver decompensation. I think that if we can clear the stones and continue the antibiotics, we might have to give him a little bit of time to kind of recover from this acute episode of infection. I think he can get better, and then we'll take care of the
Slowly
portal
did.
hypertension.
Over time, he sort of, we did. Dr.
Right.
Kaur, what do you think?
First, I mean, I think both Amy and Nantali have said pretty much what I wanted to say, and I agree with everything. It really, when I first looked at it, I said, this doesn't look like PSC. I mean, if
Right.
there's you just don't really see. But I have to qualify that we don't see a whole lot of PSC around here. But the cases that we have seen, in general, they don't look like this at all. I mean, we see some dominant strictures, we see beading, skinny ducts in the main, and not a whole lot of dilation. Here, I agree with Nantali. It really looks like oriental cholangiohepatitis, or what some people call RPC, or recurrent pyogenic cholangitis. And it's only if you look at maybe the second order ducts or smaller that you see anything that looks like PSC. So, and we're not seeing any strictures at all, apart from maybe, when you showed us that cholangioscopy image, maybe there's a bit of stricturing. And then, that stone that we're seeing in there is a pigment stone as well. And we're seeing pigment stones getting dredged out. So, I mean, if you blinded the patient, I'd say this is somebody who could be Thai or could be Chinese, or, in Southeast Asia, perhaps. So something isn't right here. I'm just wondering was there an MRCP, and really what was the original basis for the diagnosis of PSC? And is there a MRCP image or
Yeah,
from
the initial
before all this happened?
diagnosis came from Brazil, so we really don't know what that was based on. I almost feel like it was based on the fact that he had abnormal LFTs and have an ulcerative colitis as diagnosis. They just ultimately put two and two together and just say, oh, it must be PSC. Mary Lee,
Yeah.
oh, I'm sorry,
uh,
didn't mean to
Sorry,
interrupt.
Sonia, just one more thing. I mean, I also agree that there is portal hypertension here. And very likely the portal hypertension, accounts for the splenomegaly, but it may not. And there may be something else going on here. But I think it's too early for this patient to be developing secondary sclerosing cholangitis. He's so young. And it sounds like this is his first kind of episode. So maybe, something else accounting for the cirrhosis. In general, the surgeons are quite accurate when they make a diagnosis. It would have been nicer, a sort of like a visual diagnosis, but it would have been a lot better if they'd sort of taken a wedge out at the
Yeah.
at the laparoscopic procedure, right?
I'll pass it on to them for sure. Mary Lee Phoenix, do you think we should pursue portal hypertension measurement in this patient?
Well, actually, I was about to say that, when we go down with the intent of doing EUS guided PPG and we see esophageal varices, we're like, I have an extra 10 minutes of my day because it looks like portal hypertension. And usually we don't have to proceed with PPG measurement, especially if you're looking at collateral vessels. I think you have portal hypertension. It is pretty easy to do it, but I think you have the diagnosis without it.
Mary Lee, should I do it or not?
No, I totally agree with Phoenix, and Nantali already mentioned that if you have esophageal varices, your portal pressure is most likely it's greater than 12 by definition. So I don't think you need it.
Does it stop you for a few minutes that we have remaining? Does it stop you the fact that his platelets are persistently sort of above 300s, 400s? Does it stop you in any way? Do you want to see sort of a low platelet count in a setting of? I see Dr. Kaur is shaking his head. No. Everybody, what do you think? Does it raise the question? Is it really, or we have sort of the story that we were thinking of maybe is like this persistent sort of smoldering cholangitis or endocholangiopatitis with some partial portal vein thrombosis leading to this portal hypertension. But you guys think it's cirrhosis. That is, you guys all convinced?
Throw out another thing, the IgG, is that the IgG4? I mean, there are cases of patients, like young patients that have like an autoimmune colitis, or
Right.
it looks like ulcerative colitis, and they have a, intrahepatic cholangiopathy, I mean, an autoimmune cholangiopathy, so to speak. Although typically—
That's a great thought. I don't remember if we measured
did.
IgG4 and it was normal.
We did the full IgG panel, and IgG4 was normal.
Do we have his HIV status?
HIV was negative.
Negative.
One idea, you could potentially at the time, he's going to need another ERCP to remove the stent.
Yeah.
You could do a liver biopsy, EUS liver biopsy at that time. Might help try to answer the question, is there actually fibrosis, or is this all portal hypertension from portal vein thrombus, for instance?
Right. That is, so our plan, he's sort of taking a rest. And would you have done liver biopsy in this acute setting? My feeling was that I'd rather not, when he was just too infected. No, Dr. Kaur is saying no. I could see that.
Yeah, I guess we just need to let him settle down.
Right.
I mean, a fibroscan, unfortunately, his ALTs and ASTs are kind of high, so that's going to affect accuracy. But I guess if it was done right at the beginning, when it was just like twice upper limit normal, might have given us a better estimation of whether he is cirrhotic.
I'll cut the recording of what you're saying and play it for our surgeons probably in a couple of days.
Tell them I'm impressed. I'm impressed he went to the OR for cholecystectomy in the setting of portal hypertension. Every surgeon would actually.
I think they didn't realize in the beginning, I guess. I don't know, right? Yeah, it didn't appear in the beginning. And I think although the initial CT scan before the surgery, that shows some collaterals, shows some splenomegaly with a little bit of cirrhotic nodules, I think, at the liver surface. And I think that but because of the acute cholecystitis, so I think the surgeons did the right thing.
They had no
to do,
choice. He was quite sick.
Exactly.
They had no choice other than to go in. So
it's probably worth asking the radiologists to review and see if they feel that there is enough on there to call it cirrhosis. Just scanning through the sort of nodular surface is quite specific for cirrhosis.
Right. But I kind of agree with Chris. I mean, I believe the surgeons. I believe once they mentioned nodular surface and cirrhotic pictures, I think that it's got to be very obvious. Otherwise, they would not have called it. So I think that's one. The other thing is the profile, the liver profile in this patient, although it looks like he's got reverse AG ratio as well, although it's kind of difficult to assess that during an acute illness episode. But I kind of agree with Chris that once everything is improved, then we can do a fibroscan to look at the liver stiffness. I don't think we have to do a liver biopsy per se if the fibroscan shows significant stiffness, because several things have pointing to the liver cirrhosis. But I do agree that he's so young to have cirrhosis at this age. It's gotta be something. Maybe the Stone's disease has been there for a long time already. He's 30, but the Stones might have been there for several years. And maybe it's enough to put him into cirrhosis from secondary cause.
Natalie, I mean, Thailand has the world capital of cholangiocarcinoma from from liver fluke infection. Is this
Right.
an issue in Brazil at all? Do we know?
Cholangiocarcinoma or
liver fluke infestation.
Liver fluke
Not
is
in
not a
Brazil.
big thing in Brazil, no. But I think the recurrent pyogenic cholangitis might be. I think Latin America is one of the areas where we see populations of this sort. Yeah.
Right. So now I have a dilemma. So Dr. Kaur says yes biopsy. Nantali said no biopsy. I'm gonna poll everybody.
I said
Amy,
surgeons should have biopsied. I'm not suggesting we go back in and biopsy now.
Okay.
This might be a
Fibroscan
question
first, yeah.
to get a
Yeah,
hepatologist
Yeah.
involved.
We're doing
Okay.
very few liver biopsies these days. I mean, if it's just to look for cholangitis, for cirrhosis, but I guess if we, if we're, sort of back against the wall and we need a tissue diagnosis to direct management, but this would probably be kind of port of last call, I would think.
So Amy said ask
Maybe
your
just for
pathologist.
etiology, but our hepatologists really like having liver biopsies. We end up doing a lot.
Mary Lee, do I
Not just to
biopsy
look
or
for
not?
scarring, but also to help with etiology, especially if we're questioning if this is really all secondary cirrhosis.
Mary Lee, biopsy or no biopsy?
I'd say no biopsy, and I would get an MRCP.
Okay.
If we do a liver biopsy, I'd like to check that INR again.
Yeah, that's for sure. Well, on this positive note, thank you for giving us all the answers. We're gonna go to the Wignap case. Very excited.
It's going to be presented by Warpot, who's one of our advanced endoscopy fellows at Siriraj Hospital. And we have the whole team of advanced fellows as well as GI fellows in the meeting room. Thanks to them for showing up this early at 7 o'clock in the morning. And Warpot, please go ahead and present your case.
Okay. Hello, everybody. Today, I would like to share the case presentation from the Siriraj Hospital in Endoscopy Cafe. My name is Dr. Warpot Yingyontawat from the Division of the Gastroenterology, Siriraj Hospital, Maidon University, Bangkok, Thailand. The case presentation at 62 years old woman with underlying disease with hypertension and dyslipidemia. She came to the hospital with the progressive jaundice about 4 weeks. She has bowel aging, epigastrium pain with significant weight loss for 4 kilograms in 4 weeks. Her physical examination showed the vital sign, stable vital sign with icteric sclera. Her abdominal examination found no significant abnormality. On the basic liver function test, she has a total bilirubin elevation above 13.9 and direct bilirubin above 12.5. This pattern was compatible with the cholestasis jaundice. The other initial laboratory assessment was normal, except she has a CA99 about the 161 unit per millimeter is higher than normal range. This is the imaging of the CT scan from this patient. Show that the bilateral intrahepatic duct dilatation with the circumferential wall thickening inside the common hepatic duct and the common bile duct with the luminal narrowing. And this video also show the coronal view in the liver, the bilateral intrahepatic duct dilatation with abrupt change with luminal narrowing in the common hepatic duct, hepatic hilum, and the common bile duct. This is the snapshot from the CT scan. You will see the intrahepatic duct dilatation in the both hepatic lobe with this thickening of the bile duct wall with the luminal narrowing inside. Okay, what do you think about the diagnosis, this discussion?
Okay, so we're just we're gonna go ahead and discuss as we go on. So maybe
ERCP or no
Sonia.
ERCP?
Right.
ERCP or no ERCP? Who's gonna want to do ERCP right now?
So we
Emmy,
do have this patient who comes in with weight loss, jaundice, progressive jaundice, no fever, right? No fever at all. And then the CT scan show diffuse thickening of extrahepatic bile duct with some involvement in the hilar area.
Right.
I forget, how old was the patient? Because
62-year-old woman.
62-year-old.
Yeah.
Yeah.
I mean, this smells like cancer, unfortunately, I think in every way. You know, it's been sort of a slow progressive process. There's weight loss, you know, a lack of acute pain, and the way the CAT scan looks with the wall thickening and really impressive intrahepatic dilation. I would be very worried that there's a malignancy hiding right around that area where the wall is thickened. And I would say definitely ERCP.
ERCP with a spyglass on the first ERCP or just ERCP?
That's exactly what I was gonna ask, Sonia.
Well, you know.
No, I was gonna ask, because this patient, okay, ERCP versus no ERCP. If no ERCP, then this patient would be sent to surgery, right? So do we know for sure if this is resectable disease, or are any one of you guys thinking this could be IgG4 related with only extrahepatic involvement? You know, although the age, the gender is not very supportive of that, but sometimes we do see that. So yeah, so ERCP versus no ERCP. If we do ERCP, we do cholangioscopy at the first session.
Dr. Kaur, I know you were involved in the consensus guidelines that actually said that SPY at the first ERCP improves the diagnostic yield. So which one, ERCP or no ERCP? And ERCP with SPY?
I think if the resources are available, SPY right away, and I know Amy is part of all these big groups, and and I was reading the Mendoza, which is improvement on all the previous guidelines, and I just want to hear her take on this. I mean, would you? I think we would go with SPY right away because we want to get a histological diagnosis and really guide the surgeons. But having said that, there's a lot of surgeons who would go in without tissue in a situation like this.
Mary Lee, Phoenix, what do you guys think?
I would definitely go right away. It's just get the biggest bang for your buck. Go in, do SPY, I would biopsy, I would brush, I do the whole thing to get the diagnosis. Unfortunately, I mean, maybe because, well, our surgeons wouldn't go in right away. They would definitely want tissue diagnosis here in the United States.
At our
Phoenix,
center,
I-
our surgeon would ask
I think-
for
Yeah, I just
EUS
meant-
prior to ERCP. So EUS with or without?
With or without what?
So EUS prior to ERCP.
Mm.
Well, the literature really doesn't support doing FNA. You don't want to do FNA because you don't, if they're an operable candidate, but EUS, a lot of times we do EUS first just to map things out and get a better idea of what we're looking at. But I think the CT scan was quite good. So maybe you really could just go, if you have limited time, just go right away for ERCP and cholangioscopy. No, Nantali.
No, I was going to ask Phoenix. So if you were to do EUS first before ERCP, would you do F&B, or would you just kind of EUS followed by ERCP with biopsy if you see some abnormalities at the wall of the bile duct?
Uh-oh.
All right, I lost the signal.
Oh,
I
okay.
think it depends on the local area of expertise, but our surgeons really depend on our EUS expertise. So they want the full information. And I think EUS, I'll have a discussion with them beforehand, depends on the patient's age. And we are for diagnosis.
So I guess for US,
Um,
Phoenix having a little technical difficulty.
yeah, for EUS.
For US, if you were on the US, visualize a suspicious lymph nodes, that would be something to sample. Emmy, would you consider? Mary Lee, what do you guys think?
I was just going to say the same thing, actually. Usually if I do an EUS before a case like this, I'm really looking for lymph nodes that I can biopsy. Our surgeons don't really like us to biopsy the bile duct wall initially, unless we're really needing, unless the patient ends up not a surgical candidate and is going to need chemotherapy or something, then you need tissue, then we would potentially biopsy. But we usually don't biopsy the actual intrahepatic or lesion itself, but we do sometimes look for lymph nodes around the area that can give you tissue. And I think mapping it out is always reasonable ahead of time with EUS. In terms of cholangioscopy, I agree. I'd probably go straight with a SPY first time too. I think in addition to tissue, our surgeons probably would want the bilirubin to come down a little bit before they take the patient to the OR too. 13 is kind of high, so I think getting a stent in here would be a priority as well, just to drain the bile ducts a little bit. But I think as long as it's not a very difficult cannulation or a bleeding sphincterotomy, something like that, there's no reason not to do cholangioscopy right off the bat to try to even just take a look in addition to getting tissue.
Nantali, we have consensus, I think.
Yeah,
which is,
yeah. So
really unusual.
all right. Yeah, I have to say that our surgeons usually if they look at the cross-sectional imaging, either CT scan or MRCP, MRI, and if they think that the disease is malignant and resectable, most of the time they would just go ahead and do surgery. But for this particular patient, and Waraput is going to give you more story on that. But for this particular patient, this patient actually got sent to us from the surgeon, and they wanted us to perform ERCP before they do surgery. And for the fellows, just so you know that if you practice in a hospital where the technology of spyglass or cholangioscopy is not available, it is still okay to do ERCP with brush or fluoroscopic guided biopsies of the suspected area. But now you can see that all the experts are leaning towards doing cholangioscopy at first session. I think because the technology is there, it's widely available, and it gives us more information. And like Emmy said, if it's not too difficult to get the buy-in, sometimes you have a very, very narrow duct and you really can't get the buy-in, so that I think you don't have to force your way to get the buy-in. But if you can do, I think it gives additional information. So go ahead, Barapod, you can tell us more about this patient.
Okay, back to this case. The initial diagnosis is the hyalocholangiocarcinoma carcinoma. We discussed in multidisciplinary team about the plan of the management. The hyalocholangiocarcinoma carcinoma type 3A. The hepatobiliary surgeon decide the surgical option depend on the disease extension and the residual liver volume after hepatic resection. They consulted intervention radiologists for the augment volume of the left lobe of the liver by right portal vein embolization before the surgery, but the surgeon concerned the liver remnant after the resection. In the field of the gastroenterologist, we plan to preoperatively drain it before right portal vein embolization, evaluated disease extension by cholangioscope and perhaps tissue biopsy. This diagram is the disease extension. The tumor is located in the hepatic hilum and common bile duct and common hepatic duct. The first surgical plan, if the tumor invade in the intrahepatic duct below the branch of the bile duct segment 4, they will do extended right hepatectomy with Whipple operation, including the right hepatic artery and left and right portal vein. But in the bile duct, we will resection the branch of the left portal vein below the branch of the segment 4 if the tumor not extended invasion. But if the tumor extend more than the branch of the B4, the surgeon plan to the second option, the right dissectionectomy with the Whipple operation, including the B4 branch of the intrahepatic duct and right hepatic artery, middle hepatic artery, and the left portal vein, including the one branch of the portal vein in the segment 4.
So before you go ahead, Barbara, I just want to add a little bit more. So this case is actually extrahepatic cholangiocarcinoma with an extension to the hyla. It's not the classic hyla per se, because the disease is involved common hepatic duct and common bile duct. So it's actually involving both extrahepatic portion of the bile duct as well as hyla. So that's why the plan for surgery is so extensive. They've got to do combined Whipple's operation plus extended right hepatectomy, or more extensive surgery than that, and therefore they really have to augment the potential remaining liver by doing right portal vein embolization. So it's a combined extrahepatic and hyla.
I would just say too,
cholangiocarcinoma.
like this is another great indication for cholangioscopy, not just to get tissue and look at the tumor, but actually to map out how extensive the tumor is. So if you're able to get the cholangioscope beyond the stricture or the obstruction, you can actually go into the intrahepatic ducts and try to see how much is involved.
And yeah, and Emmy, that's exactly what the surgeons wanted us to do. They wanted us to assess the extent of the disease. And Amy might have crystal ball, because she said if we could get the scope across the stricture. Well, our Warport is going to tell you how far we had gone into the bile duct. So go ahead.
We published a study actually on and mapping like this actually can change the surgical plan in a lot of cases.
Exactly.
Do you, in this quick
my
question,
surgeons sometimes come into the room and want to watch, you know, as
quick question on that. Do you guys biopsy actually normal appearing lining of the bile duct? Because I sometimes, even when it looks endoscopically normal, I've gotten positive results from that. If you pass the,
in the paper, In the paper I published a couple of years ago, we did not. We just used visual inspection to determine the extent of tumor involvement. But I think, you know, certainly the next step is to look at histological mapping as well.
So here's the answer comes.
Yeah,
How
but
did
I'm
it go?
curious
Okay.
if you're going to get through. That's always the most
Okay.
difficult part.
Okay, and we perform the ERCP after the surgical plan. The contrast cholangiogram show the left intrahepatic duct dilatation with abrupt absent contrast fill in the hepatic hilum and the extrahepatic common bile duct. We did blood cytology, and then we do the perform cholangioscope in this video. The cholangioscope can pass through the hepatic hilum, and the common hepatic duct reveal the diffuse erythematous papillary protrusion with a regular white duct wall along the hepatic hilum, common hepatic duct, and along the common bile duct. Then we biopsy at the distal bile duct for the confirm the pathological diagnosis.
So basically, Amy, we were able to get the spy scope up to the hilum, but we couldn't make that turn.
Yeah.
That turned into the left intrahepatic duct. Forget about the right duct. It's almost like no way to go in. Waraport, if you could just play that video one more time. If you
Okay.
look at the hilum, I think this is a pull through. Yeah, so we started showing you at the hilum. That's where the hilum is.
Yeah.
And with wire guided, we couldn't get the spy to curve along that stricture. So we pulled the wire out and tried to do a freehand technique as well. Didn't work. So basically we just stopped at the hilum.
Yeah, I think unfortunately that's pretty common scenario. Sometimes if you're able to get a wire and you put a stent across, you can sort of come back a couple weeks later and the stent will have dilated things enough that then it's easier to get the cholangioscope through, but it depends on the surgical plan and if they want to wait that
Right.
long.
Not-
Beautiful.
not
what
beautiful
yeah,
cholangioscopy images. Really,
right,
really.
yeah.
Yeah.
So Chris, what were you
Yeah.
gonna say? I was gonna ask you, what do you think
Yeah.
about this?
You know, I was just wondering why the brush cytology was done before the cholangioscopy. Presumably it was in the same session, right?
No, it was
And,
done after. It was done after.
Okay.
Yeah.
Okay.
And generally, if I were to do cholangioscopy anyway, I would not inject too much contrast because it's been my experience that patients develop fever. You know, like especially those who came for lethal lithotripsy, like almost 100% of them develop fever within the first 24 hours after the procedure. This patient, I felt like she's got a little bit too much of contrast in the left intrahepatic duct before we put the spy in. So if you know, I don't know what you guys practice. It's like any contrast, any cholangiogram before going in
Mary
with the
Lee, what is
spy.
your practice for Phoenix? Mary Lee, what is your guys' practice? Do you guys put contrast in?
I do. Of course, I'm giving them antibiotics ahead of time before I start the case. They have those going in. I try to, not put a lot of pressure. I always tell my assistant to inject, not with a lot of pressure, just hoping, but I do want to see what things look like ahead of time. So,
Before cholangio,
I know we have the CT scan, and in some cases you may have an MRCP, but yeah, I do. But that's a good point.
Dr. Kaur, what is your practice in this regard?
Yeah, we do use contrast and generally only where we can get the wire in easily. Same principle, we don't want to be, opacifying any ducts that we can't drain.
Right. So what did you guys do?
It's a beautiful
Hey.
cholangiogram.
Right.
Cholangiogram.
Yeah.
Yeah.
Okay. From this cholangioscope, what is the cholangioscope impression, and what is the next step of the treatment in your opinion?
Right, which I think everyone agree upon cholangiocarcinoma.
Right. I don't think
Right.
anybody's arguing with that, right?
Right, and everyone agree upon tissue biopsies, plus minus brush cytology. I don't know, do you guys do the whole thing? I think Amy does the whole thing, and Mary does the whole thing too, like biopsy and
Yeah,
brush.
we do the whole thing too. Yeah.
Okay,
You guys
yeah.
brush?
For regular forceps biopsies from below.
Yeah, me too, all of the above.
How many
Okay.
biopsies?
How many
biopsies?
biopsies?
Depends on my energy level that day, you know.
Same
That
here.
is the-
Same here.
No,
And
Yeah.
do you guys get
Pretty
good
much.
results with brushing? You feel
the
that
more
adds?
the better. And
No,
brushing oh, go ahead.
go ahead. Yeah, I
No,
was
no,
gonna
please.
say I brushed the stricture area, like I brushed that left intra the turn into the
Right.
left main basically. I brushed that, but then in biopsy the extrahepatic bile duct,
I see.
because I wanted to kind of be sure that I get all the involved areas.
But Mary
yeah.
do you brush?
I do.
Isn't that the yield, guys? Isn't the yield of brushing is very low?
Yeah, but brush plus biopsy is higher.
Sure.
Yes.
But how much higher?
And occasionally you'll get that brushing that comes back positive, and then that
That's right. Yeah.
convinces you to keep doing it.
You don't brush, Sonia? You don't brush?
I
You don't
promise
brush?
my fellows that I show it to them twice a year, that brush, and after that, I feel like the check mark is done and that I'm done. Yes.
Oh, okay. All right, so go ahead, Warput. So
Okay.
tell us.
We did the preoperative belly drainage by the plastic stent placement, and the pathological report show from the brushing and the biopsy moderately differentiated adenocarcinoma. Yeah,
Here
you're
we
correct.
go.
The high-rise cholangiocarcinoma.
So was there a spy bite?
Yes, that was a spy bite.
Yes.
Okay.
Okay. 2 weeks after the belly drainage, the bilirubin declined from the 14.5 to the 2.02. And she underwent the right portal vein embolization. The portography showed the normal branching of the portal vein without the filling defect. After the embolization, the portography showed the complete obliterate of the right portal vein and non-target embolization of the periphery left portal vein. Okay, and 4 weeks after the right portal vein embolization, she underwent CT liver volumetry. The CT volumetry revealed the hypertrophy of the left lobe and the caudate lobe. The total liver volume about the 1,500 cubic centimeter. The left lobe was about 684 cubic centimeter. The left lobe liver preservation after the embolization is about the 45%.
Before you go ahead, Warput, let me ask experts here. So what's the at your center, what's the percentage? What's the liver volume that the surgeons accept?
Dr. Kaur.
Yeah, it's around the same 40%.
Okay. So
What is
here
it
they
for you,
they
Anya?
kind of like to have it above 45, but I guess 45 is still acceptable for them. Well, what about you, Amy?
Yeah, about the same, I think.
Okay.
Ours are very conservative, so at least
Oh.
45. What about
Okay.
Mary Lee, Phoenix? What are your guys' cutoffs for that?
Yeah, about the same. They also are, 45 around there.
Okay. So I think for this patient, we're kind of lucky that, after the first right portal vein embolization, we were able to augment the left lobe up to about 45%. And the surgeons accepted that. Otherwise, there are several patients of ours that had to go for a repeat right portal vein embolization to increase more of the liver volume. Yeah. Okay, go ahead, Warput.
Okay. The residual volume after the embolization more than 40%, but this is the minimal acceptable. But she developed the neocarcinosis peritonei and the distal nodal metastasis. Finally, the tumor was unresectable. After the CT scan, about 2 weeks, she developed the acute cholangitis. The total bilirubin is elevated to 3.8. And she did the second ERCP with metallic stent for the belly drainage. A few months after the ERCP, we received the information that she died from the necrotizing pneumonia at the other hospital. Thank you.
Yeah. So this is a patient who had everything that could have been done for a cholangiocarcinoma done, but at the end she couldn't really make it to the surgery because of the tumor become unresectable, which happens a lot here actually, because by the time you make the diagnosis, by the time you got the first ERCP, and by the time you got the pre-operative procedures, then a month went by, 2 months went by. So by the time that the patient was supposed to have surgery, then the disease stage had progressed, and they ended up dying from infection. This patient died of pneumonia, but I would say more than 50% of our patients would die from cholangitis, recurrent cholangitis. Yeah. So that's
you could make the
that's a
argument
common
that if this tumor progressed so quickly, just in a month or two, then probably, even if she had gone to surgery from the beginning, it probably would have come back, because it seems like it was already probably more advanced than
that is
realized.
true.
And,
Right.
Yeah.
Yeah. More
probably
advanced than, yeah.
more aggressive.
And
You know,
biologically,
sometimes-
this is aggressive
Sometimes surgeons
disease.
will use that a little bit of time to let the tumor kind of declare itself and be like, is this the type that's, going to stay nice and stable? Or is this one of the more aggressive ones that's going to progress rapidly? And there
we
was
have
quite
to
a bit of
try.
tumor involvement.
Very good point. Yeah. Amy, very
But
good
we have
point
to
there.
try.
Right.
We have
Right.
to try.
Yeah.
Yeah, no, I mean, I think if that hadn't happened, going to surgery would have been the right call, but
Right.
maybe it saved her a huge operation that wouldn't
Right.
have actually been that beneficial in the long run anyway. So,
Well,
Right.
that is a
really
great point.
unfortunate.
And on this great point, I think we're coming to an end. This was very enjoyable. First of all, I want to thank our fellows for an outstanding presentations. Thank you so much. And to our experts and our co-directors, we're so grateful. I think that was fun.
That was great. Both cases were great, I think.
Yeah, I think
Yeah.
Really
and
nice
we learned
cases.
something. So
Yeah.
we're hope to reach out to you and do it again.